All right, bear with me while we adjust this for height equity. I've always really identified, I don't know if you've all seen the image of the fence to describe the difference between equality and equity. Equality is everyone gets the same height of box to see over the fence, and equity is when the very short people get a taller box. I will also accept lowered microphones. There we go. So I want to thank Glenn so much for that warm welcome, as well as for the invitation to be here as part of the lecture series tonight. Thank you to all of you for making the trip to be here. I'm a rural girl myself. Long ago, I was born in Grand Prairie and raised in Rocky Mountain House. So I know that having something fun to do on a Thursday night in town is an entertainment not to be missed. So I definitely appreciate your presence. If I can throw in one little announcement of my own, the Parkland Institute holds an annual conference every year. Ours is coming up in November 21st. And if you like what I have to say up here and need some more of it, I'll also be talking about healthcare, and we'll be discussing some of the threats and challenges facing Canada's democracy and Alberta's place in that in the years ahead. So feel free to look that up. We're parklandinstitute.ca. And a lot of the research that I'll be referring to here this evening, while some of it comes from national academic studies by some healthcare trade unions, and some of it is my own research, which is available free for download at our website, Parkland Institute, and some of it as well through Friends of Medicare, which asked me to produce a report on access to care in Alberta in 2025, and what does that look like. So if you want to dig further into the numbers, those are some of your sources and places to start. The Friends of Medicare report is called Access Denied. So I had wavered between putting together something quite formal versus something a little bit more freewheeling and humorous. It's really difficult to have a sense of humor about healthcare or about a lot of things here where we're at in the current climate in the world at the moment. And unfortunately, I'm also privileged to have the guardianship and care and love of my 4 children, which means I've had them at home for the last 3 weeks during the teacher strike. So the sacrifice here was my slide deck. You get to listen to me, and I'm going to try to paint you a picture with my words. So I was thinking a lot about how I could begin to frame this conversation, because it's a little tongue-in-cheek, but so much of what we're facing in healthcare, especially right now, feels very heavy. It feels quite negative. It feels sometimes like we're moving backwards. And unfortunately, I am going to be going into some of those difficult numbers and asking maybe some harder questions about where we are. But I also want to be able to reflect on where we can go and what are our possibilities here in Alberta, our possibilities as Canadians in thinking about our public health care and what it means. So kind of pulled between these, the yin, the yang, the doom and the hope, and hence between maladies and remedies. And I hope you come out today thinking a little bit more about other remedies, maybe ones that I haven't thought of as well. And what really helped me to put some of my thoughts all together, so I'm not just up here making everyone cry or raising your blood pressure, is an open letter that my friend Chris Galloway wrote last week. And you might know Chris as the executive director of the advocacy group Friends of Medicare. Chris wrote a letter to the federal, provincial, and territorial health ministers as they met in Calgary last week. And he asked them, and I think all of us, to consider what makes Canada, Canada. Now, I come from a background of political theory and international relations and deeply divided societies, which I'm going to go into next. But so I'm really, really aware about what the current national and global context puts onto a question like that. We're in a moment of geopolitical and economic turbulence, threats to Canadian sovereignty and Canadian unity. So this might have been a simple question, but right now it feels weightier, maybe more existential than it did back in the days of the old Molson rant. What does it mean to be Joe Canadian? And so that question stuck with me, and I'm hoping to take some time over this evening to untangle why. So before I entered the world of health policy research, I was a political historian of international relations and of deeply divided societies, and particularly around the issue of collective memory. So that is, what are the ways that nations and provinces use stories about us and them and our past and our future to navigate these shifting power dynamics between and within states? So nations and provinces, we tell stories about who we are, and those stories have political power and political consequences. So what does that mean for this talk, for healthcare in Alberta? I want to connect this because there are many possible answers to Chris's question, but he settled on one that he'd heard frequently over a number of years from other Canadians, from other Albertans. Our universal public health care defines us as a nation. And if you look at polling from around a decade ago, it would show that about 90% of Canadians support that statement. So as we're seeking to strengthen our country against the current global challenges, tying Canada fundamentally to public health care does something. It does more than simply call for a defense of our healthcare status quo. It does more than call for more funding. It allows us for a moment to claim healthcare as nation building. This is the word of the day amongst the new federal government. Okay, so what does it mean? Does nation building just mean pipelines? Does it just mean nuclear power? Does it just mean industrial endeavors? If healthcare is nation building, that means it's an essential pillar in our economy and a guardrail of our social democracy, as well as the foundation of our national identity. So that's one story. And it's a story that comes with a deep history that's peppered almost with a kind of mythology, like parallels to Britain's NHS, National Health Service, the emergence of the post-war social welfare state as this sort of monumental project of national reconstruction. And we see in this mythology the pioneering figures of in Britain, someone like Nye Bevan. Here in Canada, we hold up Tommy Douglas. We have the principles, the 5 principles of the Canada Health Act, which turned 40 last year without actually a lot of fanfare. So did I. Yeah. So there's also the many benefits that followed on from this. It's not just an intangible idea. It means to have a public health care system, increased life expectancy, decreased infant and maternal mortality, medical breakthroughs, the prevention of widespread death and illness and disability through vaccination and screening programs, a reduced cost burden to individuals and families and communities, and also the economic and equity impacts for women primarily, as that unpaid care work was shifted into a professionalized stream of healthcare careers, which are still, especially here in Alberta, primarily held by women. So undeniably, universal health care is a remarkable achievement that has been key to our progress over the last 60, 70, 80 years. But, everyone's not like, but, at the same time, we cannot deny that our healthcare system is in crisis. We kind of hear daily, weekly, there's another crisis, there's crisis upon crisis. But primarily, when you take all of those apart, it's a crisis of access. So if healthcare is our foundation, it's an unstable one. Nationally, provincially, and locally, what might have been these little hairline cracks a decade ago have threatened now to become a crevasse. And if healthcare is no longer universally accessible on the basis of need and not location or demographic or ability to pay, then it becomes emblematic of failure and division rather than progress and unity. And if healthcare is one of the central pillars of our social democracy and our economy and our values, if it topples, does that mean Canadianness is also at risk or needs to be redefined? So I want to think about this mythology, this legend about universal health care that is so important and so central to the story about Canada. And I want to put alongside it the one that we're also really familiar with the story about Alberta. And we have stories about ourselves, about what Albertanness means. Stop me if you've heard this one before. So Alberta is at heart a conservative province that won the lottery. Our public services are eternally tied, for better or worse, to the fortunes of the price of oil. And that's a reality that we can't change. Now, like all stories, this one and the wider national one, there's little elements of truth and there's a whole lot of missing context. So I want to trace these stories, I want to untangle those contradictions, especially around the ways in which public health care is woven into our country and our province, and to think about what kind of forces are working to unravel that. How did we get here to this place of perpetual crisis with our public services as the battlegrounds? Thinking also of our teachers today. So what are the implications for the future, and how can we move beyond political division to a place where we can rebuild healthcare on a foundation of common values? It's a small task. We've got till 8 o'clock. It should be all right. Again, I'm also telling a story. So keep in mind, it's truncated, it's short form. There's villains, there's heroes, and again, there's a lot of pieces and details missing in between. You guys will all know that, so just for the audience at home. Our crisis isn't new, particularly here in Alberta. It's not unique to Alberta either. But it has roots in so many of the policy decisions that were taken by past governments, that were doubled down on, that exploded spectacularly, and yet we collectively, we did not learn from those policy mistakes. We've been on a trajectory. There have been stops and starts, and it's difficult to look from where we are and say, well, how could it have been different? So that's not to say that we always were going to get where we are, that it was inevitable, or that there was some utopia in which we never had to deal with any challenges. But we'll say, there's a key coalescence at a certain point in our recent history between the forces of neoliberalism and privatization, and his name was Ralph Klein. And yes, I am old enough, barely, to remember those days quite vividly. And this took the form. Klein's my stand-in guy. He's the heel in this story, but he doesn't have to be. It's not to demonize him, because his policies reflected an approach that was championed by Margaret Thatcher and Ronald Reagan and various other premiers across Canada and in other places, in the British Commonwealth, who were trying to apply the laws of the market to governance and principles of efficiency and competition to the public sector. But Klein became the figurehead for these ideas, partly due to the vehemence of his rhetoric, as well as the lengths to which he was willing to go to implement them. So his characterization of the choice for Albertans in 1993 as between Decor's brutal cuts on the one hand and his own massive cuts on the other, it sets a framing of a very different story for Alberta that has actually been very resilient over the last 3 decades. We seem to always be looking for the cuts over our shoulder, even in times of prosperity, even in those oil boom times and times of surplus. So we've also seen that sort of Klein's repeated attempts to create a third way, what his term for a two-tiered healthcare system that involved both public and private out-of-pocket or for-profit services, has also been I use the words a particularly persistent poltergeist, and it was a poor alliteration on my part. So healthcare in Alberta really struggled from this point. The massive cuts were 20% across the board in healthcare. And it generated a sort of perfect storm where the other cuts that were implemented to social programs increased the level of social need. And where does social need end up ultimately? In the ER. It ends up in healthcare, one way or the other. But this increased need came at the same time as an exodus of trained healthcare workers. A lot of my own family members took up positions in the United States or in other provinces. And even though subsequent premiers ended up reinvesting and trying to bring those levels back up as the economy improved and as their political capital increased, we never actually returned to those pre-1993 levels. At the same time, we had a lot of changes on the ground in how healthcare was delivered in Alberta over the last number of decades. In particular, in 2008 and 2009, the creation of Alberta Health Services. And at the time, this caused a lot of organizational turmoil, years of political tension between its boards and various health ministers and CEOs, even though it would become a highly successful model for healthcare delivery. It had the lowest administrative costs of any health authority in Canada and in much of our comparative jurisdictions as well. So despite all of these things, it hasn't been a boring time to think about healthcare. When anyone think back and be, oh, I remember when healthcare was boring. Things just sort of chugged along. There was always enough funding. There was always enough workforce. We were never worried that the rug was going to be ripped out from under our services and it was all going to be rearranged. It feels like that's a fairly, if not constant part of the story, it's certainly one that dips in and out of it. And now some of that is actually due to the nature of Canada's healthcare system and not just the quirkiness of Albertans. As Dr. Danielle Martin and her co-authors have put it, I'm going to paraphrase her, but Canada's health system is less a unified national system, and it's more like 3 regional systems in a trench coat, right? And I'll do a song later, I promise. There's also the limitations of the Canada Health Act. Even though it's fundamental to making our system work, it's very narrow, it's very partial, it's very specific in some ways and really broad and ambiguous in other ways. And there were these aspirations from the outset of Canadian Medicare to expand into something more like a fully universal, broadly applied public system to cover pharmaceuticals and dental care, which we've tried to make a stab at in the last few years, optical health and mental health. But these things have felt somewhat illusory, far away, as advocates spend a lot of their energy just fighting to stave off these incursions of private profit into the gray areas and the margins. So some of that is deeply relevant to how we are where we are today. And I thought of it a little bit like, you'll forgive me because I'm thinking of a lot of some of my academic work, in particular a quirky little book by Jacques Derrida, but I always think of like, what's the specter that's haunting the room? And the specter that is haunting our healthcare today, right now, that continues to have repercussions is still the COVID-19 pandemic. And all of those little, I don't mean to minimize, but all of the challenges, all of the ups and downs that we had experienced as a province and as a country, the trying to expand and build up and the trying to rein in costs and curtail excess were perfectly magnified by this phenomenon that hit us like a typhoon. And we may think that, you know, with the sort of receding, but not elimination, the receding of the virus itself, some of the consequences of that upheaval would also start to be rolled back, and we'd go back to something like the old normal. And that really hasn't been the case across much of society, but in particular, we're seeing that magnified in our healthcare system. And the consequences continue to be felt in our hospitals and clinics and long-term care homes and across our communities. It's still putting excess pressure onto our health system. There's a continued fallout in the health workforce in the form of burnout and trauma, in the form of illness and long-term disability, and also an ongoing sense of demoralization and change fatigue. We just want things to go back to boring, even if boring never happened. And there's also, all of this has been happening with a very constant backdrop of political and social backlash to the pandemic policies and how it was responded to. So the pandemic has also left in its wake a really deepening social disconnection. It's exacerbated mental health challenges and addiction and homelessness, impacts to livelihoods through layoffs and business closures and a changed nature of our economy. And the political responses to try to tackle all of these challenges have been really mixed, and in many instances have actually further contributed to the ongoing sense of crisis. And at least, sometimes I say, the pandemic was an unexpected circumstance that far exceeded the level of routine planning. They call it a natural disaster for a reason. But many of the other crises we're going to try to dig into are like disasters of choice, like deliberate policy decisions by various governments and officials that should have set off alarm bells. And I know because I was ringing most of them. It's getting a bit tired. These were pushed ahead, heedless of the potential cost to Albertans and heedless of the voices calling for caution and calling for more evidence. Okay. I would like to poll the room. If you can think of an example that's glaring, you might say lab services. I have a lot of good friends in lab services. They were ringing the alarm. Things like the chartered surgical facilities. Folks were ringing the alarm on for-profit surgical outsourcing. So unfortunately, if I went into each of these in extensive detail, we'd be here for a long night and it would be really depressing. So I'm going to give a little overview about some of those. Where are we? What are the implications of where we are? And what are the repercussions for access to care, for transparency, and for fiscal accountability? Because how we resolve these crises will set the direction that we're able to take in the future. So the biggest one that's continuing to impact all the other aspects of our healthcare system is the workforce crisis. To throw a whole bunch of numbers at you, we'll put it this way. The AMA estimates that here in 2025, nearly 1 million Albertans will be without a consistent primary care provider. That's 1 in 5. Okay. Part of that is due to a disappearance of doctors in terms of our net overall total. We're bringing new doctors in, we're trying to find initiatives to encourage doctors to stay. The AMA as well in 2024 surveyed their membership, and they found that family physicians and general practitioners in rural and remote areas, 6 in 10 were planning on leaving either Alberta or leaving the medical profession. Of that 60%, 3/4 of those were making plans within the next year to close their practice or to up stakes. When we look at the number of doctors who are accepting new patients in Alberta, in 2024, we saw for the first time in a number of years, actually an increase in that number, which is amazing. But we went from 1,000 doctors accepting new patients in 2019 to 275 accepting new patients in 2024. That was an increase from 204 in 2023. So while it's the nature of politicians in particular to point to the positives and say, look, we're increasing our numbers of doctors accepting patients, when you look at that long-term trend, we're still in a really deep hole. Why are we still in a really deep hole? And a huge part of that comes down to 2 connected policy decisions. One comes along with a little tagline, oh wow, we're gonna be here a long night, I just got my 5 minutes. One comes with the tagline, Alberta is calling. We have had a massive influx of newcomers to Alberta. And this was a policy choice in these times, looking around at the world. I just wanna deviate from here. In these times, certain people will tell you to blame immigrants. Those same people will not tell you they set up a fund. They set up advertising and billboards to bring the immigrants here, to bring people from other provinces and from other countries, without setting in place the funding for the public services and the infrastructure that would be needed to support them and to support Albertans who are already residing here. That's number one. Along with this is an explicit mandate for each of the ministers, including the Minister of Treasury and Finance, to keep public spending below the level of population growth and inflation. Which, as a policy nerd, that's your benchmark. Anything below that, you're not keeping pace. Somewhere, something has to give. You're adding more people and experiencing greater costs and trying to do it for less. What happens? Someone loses out or quality falls short. And we've seen what that means, particularly outside of Edmonton and Calgary. We've seen in small communities and in rural hospitals, rolling and ongoing and persistent ER closures, obstetrical closures, closures of acute care beds as well. In 2023, the combination of all of those closures, oh, it's only 6 days here, it's only from 5 till midnight or midnight till 6 a.m. on every second Thursday. It adds up, and it's not there when Albertans need it. In 2023, those closures accounted for 3,000 lost bed days across 39 communities in Alberta. Some of them had these rolling closures or loss of services that went back to 2020. They're temporary. Even in 2024, yay, we're improving. I wanted positive news for you. Those closures impacted 29 communities instead of 35. When we look at our hospital capacity, it's also not keeping pace. Between 2019 and 2024, our number of acute care beds across Alberta increased by 3.6%. Yes. Positives, right, folks? Population increase, 13%. What happens? Well, you have to find somewhere else for folks to go when they need care. At the same time, between October 2023 and October 2024, Alberta lost 20,000 more healthcare workers than we gained. Between 2023 and 2024, the number of vacancies across our healthcare system increased by 17%. It was a total of 5,370 vacancies during that period. Right. When we talk to members of healthcare professions, and I'm sure if there's some of you in the audience here, all we hear, it doesn't matter the sector, it doesn't nurses, healthcare aides, lab technologists, people in speech therapy or x-ray or pharmacy, they're all telling us the same thing, and that's that they are burnt out, they're exhausted, they feel hopeless because they are in this profession to provide care. And the circumstances around them are making it so difficult to do that and forcing them to make impossible choices. Some of those choices impact the quality of care they're able to give or the number of people they're able to care for. And some of those choices are impacting their own well-being. Skipped meals, skipped bathroom breaks, working during sick days, pushing through when you're shorthanded to the point of exhaustion, and needing supports for yourself from a healthcare system that now can't support our nurses and our HCAs when they need it. So I don't want to eat too much into the time for discussion because I feel like he's on time. That's why I married him. I feel like the best thing that we can do, and I'm going to get to this part, the best thing that we can do for our healthcare system going forward is to learn from each other and have empathy for each other's experiences. So I want to leave some time to have that discussion and to have questions from all of you. So I'm going to skip over the crisis in lab services. I'm going to skip over the crisis in our surgical services, the corruption and the profiteering and the absolutely ineffectual process that has raised wait times rather than lowered them. I'm going to skip over the dismantling of Alberta Health Services based on a whim and a petty grievance. I'm going to skip over Bill 55, which has now shifted ownership of Alberta's hospitals to Alberta Infrastructure to allow them to be sold on or leased out to private third-party corporations, and will allow the delivery of our healthcare services to be bid on by for-profit contractors for the lowest bid, not the highest. All of this adds up to, where are we now? An erosion of care, and a corporatization of care, a profitization of care that would put the ghost of Margaret Thatcher to shame. And if it feels like we're in a perpetual crisis, how do we find the energy to be hopeful and to reimagine something better? That's the fun part over with. So what we have to do, and I want to hear from all of you about maybe how we do it, is to come back to something that begins with our common values. And it means asking, what is healthcare for? And who is it for? And what are we willing to sacrifice and to stand up with and for in order to ensure it's there for everyone. It's there for ourselves and our families and our communities, and there for others. And this means going back to evidence. It means going back to the solutions from the experts. The experts aren't nerds with research up here. Like, it's our frontline workers who have seen what works and what doesn't, and they have ideas. They are shouting from the rooftops about ways that they can be supported to deliver the care that they came into this profession to deliver. And above all, it means recognizing that healthcare is intrinsically about human care, and that when we provide that, we see the benefits as a society, and some of them are economic, and some of them are personal, but all of them make this the country that it is. It makes Canada, Canada, and Alberta, Alberta. Thank you.
Thank you very much for your insights and diagnosis of some of the problems in our healthcare. I was wondering if you could expand on and help, I guess, parse the concept of publicly funded and privately delivered versus publicly funded and publicly delivered. My understanding is that general practitioners would be a for-profit business, publicly funded, privately delivered. Our radiology group, for instance, in central Alberta, would be publicly funded, privately delivered, with a for-profit model. The recent money being given to dentists would be publicly funded and privately delivered in a for-profit business. When it comes to surgery, it seems that society wants to have it publicly funded and publicly delivered. Could you expand on why we've set it on surgeries but feel comfortable in other areas of medical delivery?
I really appreciate the question, and you're right, because there are these complexities within it. And to start here. Some of this, as I said, goes back to, and you'll know this, the creation of our healthcare system in general. July 1st, 1962, when the single-payer, medical system was created, and the Saskatchewan doctors went on strike. There has been opposition, from doctors in particular, but from other healthcare providers, to the perception of, government interference, government setting limits on the amount of practice and profit. Don't know what I've done here. I'm allergic to talking about all these things in here. Pardon me 1 second. So the reason, here we go, we got it. Haven't had this much mascara down my face since I went to that comedy show the other night. There was three lads from Dublin. Anyway, I highly recommend it. Part of the reason that doctors were permitted to remain as these private incorporated entities was the compromise to mitigate that strike action at the initial creation of single-payer Medicare. Was it ideal? There were trade-offs with it. It's very, very different, for example, from the NHS model, where physicians and doctors of all kinds are employees of the National Health Service, and for the most part are paid salary in addition to a fee for service. But so some of that's about the peculiarities of it, and I do differentiate I don't know quite what the language is for it. To differentiate between Dr. Graff McRae Incorporated and I'm hanging up my shingle and running a practice, which increasingly family practitioners are hesitant to do because of the business aspects of it, versus something like Loblaws, which is a multi-billion-dollar, multi-pronged organization that exists primarily to generate profit. Even its healthcare sectors, their mandate is to generate profit while providing healthcare. My physician, I don't know about yours, maybe it's different. My physician, her mandate is to provide healthcare and also to pay herself a wage and to pay her staff, right? I don't know if there's a technical differentiation there, but when we talk about the corporatization, it's in the sense of when 4 companies own all of the newspapers in the United States and Canada versus Jim Incorporated, who owns the Rocky Mountaineer at one time. So corporations, I'm using it as a shorthand in that sense. The difference that we see is across systems. So when we talk about private delivery, we see the ways in which across seniors care, across lab services, across surgical services, all of these when they function as businesses, they have a mandate to generate profit. And in order to generate profit, they need either additional funding, or they need to pay their workers less, or they need to have fewer workers, or they need to provide somehow a cheaper service. They need to reduce their own costs. Like, the math has to math in order to generate a dividend to shareholders, right? So the difficulty here is what has to happen in that scenario versus giving the same amount of money to a publicly delivered service that operates on the standard of care. And over all of these various studies, in each sector of healthcare, they find worse outcomes. They find worse outcomes for patients. They find worse working conditions for healthcare providers. And they find that by and large, where those two conditions don't exist, it's because those private entities are cream skimming. They're reducing the complexity of the cases that they take and leaving the higher complexity services and cases to be handled by the public system. When things go wrong in these circumstances and a patient needs follow-up care, they seek that in the public system. So the costs and the complexities and the challenges are returned to the public system, while that initial profit margin stays with the company. And this is the problem that gets compounded over time. So I don't mean, for example, that I don't know the owners of the Alberta Surgical Group, for example. Never met them. I'm sure they're lovely. I don't mean that anyone is a bad person for working in these types of organizations, or that there's some kind of fundamentally evil nature of these things. What I'm saying is that the purpose is different. And when that purpose is about generating profit, it's not compatible with providing the same level of care under the same conditions. Does that answer the question in a roundabout way? I hope so. Sorry.
Good evening. Thank you very much for your historical and the information that you've provided us. I was just wondering what you thought of the idea of the municipalities or people in this room getting together to form our own health co-ops, purchase the hospitals, purchase the buildings, and start to run them and operate them as community, rather than relying on the Westlands to put you a Shoppers Drug Mart where your doctor can rent an office so that they can charge them more money than. Why is there doctor's offices in Shoppers Drug Mart? Think about that one. Why are they there? And we've got to take back our health care as a community and start working with other communities and own our own health care system. Maybe we need to eliminate provincial government.
Just take out the middleman altogether. Well, I think that's a really positive proposal. I think that's the right idea in the sense of we do need to be creative and we do need to think about how do we reimagine the way we deliver health care. And so far that conversation, it's been stuck in a gear for a long time of, innovation and the creative solutions can only mean privatization in the conventional form we're talking about, or it means kind of clinging on to what we have, even if what we have isn't quite working the way we want it to. And so I think that where we are starting to see success is with some of those sort of out-of-the-box initiatives, and they have been through local communities getting together. And some of that has been really successful in terms of recruiting healthcare workers, in particular doctors. Lethbridge was without obstetricians for a number of years and really suffering with having to send women and families outside of the community. And they've managed to band together, like you say, using sort of their collective influence to bring 7 or 9 OBs into the local area. So, places in BC and Ontario and in the Maritimes have been trying to do this for a number of years to bring family physicians. What can we offer? And sometimes it's more money, but sometimes it's not even about the money. This kind of goes to my point. Sometimes it's about the flexibility or the balance or, the community that you can offer, the connection. And so I think that there are these unique selling points that can be, really attractive and can be sort of amplified and built up to do that. So pitch it. I'd love to see it.
I'd like to address and speak a little bit about what the first gentleman spoke about, because I've been somebody who was diagnosed with cancer, and the time I had to wait in the public system was not acceptable. I was able to pay $900 to get my CT scan the next day after phoning that private clinic. Now, I understand not everybody can afford that. But by being able to do that, my doctor got the results that afternoon. I had the surgery to remove that tumor within 2 weeks. And so there are situations where the private system could be very beneficial. If we were to look at the model in Switzerland, where if you don't get the service or the surgery you need in 90 days, you go to the next tier. And if you don't get it there within the next 90 days, you go to the next tier. But it's still all publicly funded. They may be privately run, but at least the service is being delivered. I think one of the things that is confusing for folks is that everybody thinks, well, we don't want the American system. And you're damn right we don't want the American system. It doesn't work either. But if we continue to do the same thing, we're not going to get the benefits that we need. If you look at a private clinic in Quebec, the surgeon there, the orthopedic surgeon there, was ready to retire but saw the need. He offers, orthopedic surgeries 4 days a week. His nursing staff were either ready to quit or ready to retire. They didn't want to work, do evening shifts and such. And so there's ways to utilize those folks so we don't lose that brain. We don't have the total brain drain from them. Yeah. So I think there is a space for private health care, but not the American system. We need to look very clearly at the system in Switzerland because it's highly successful. With everybody, they get paid for the services offered, not a bulk sum. Here's your $15 million for the year. Spend it however you want to see it. They get paid by services delivered.
No, I think that's a really fair point. And I want to, to really highlight that when it's your health or your loved one, they're suffering, they're waiting, all of these interventions are time sensitive. No one is, seeking faster healthcare, I think, frivolously in the current context. I think that we also do need, and I know this of having been, in these networks of public health care advocates, because we believe in this and the evidence shows, right? But we get into our heads a little bit about that and saying, we don't want to start painting people who need service and are finding ways to get the service they need to save their lives, to save their health, to prevent suffering. That's legitimate, and it shouldn't be demonized, and it shouldn't be completely blocked off from, certainly it can't be blocked off now without some kind of, like you say, complete reimagining to ensure that if you are going to have, for example, a 100% public system, it doesn't exist, but you have to then make sure it meets everyone's needs in that same way. And so it's not to say, yeah, she jumped the queue, right? Sure, there was somebody who, no, we can't get into this division around it. And so I do want to say those are great points, and learning from those other jurisdictions, how do we find that balance? But a really, really big part of this is not sweeping the legs out from under what's left of our public system and then saying, oh, but look at this shiny path over here that's paved in gold. And I think that's the difference, is where we're at now. People have to take whatever avenue they have. But we had a choice not very long ago to continue to reinvest in different solutions within the public system that hadn't been fully utilized and that hadn't been given space to perform the way that it needed to. So I think lots that we can learn from that. So thank you so much for sharing that.
Putting aside the thousands of people coming into this province, what has been the impact of this big bubble of us baby boomers being the seniors? That I would have thought that would have been a big struggle for the health system to take care of. I've used the health system so much in the last 10 years compared to the previous 40 years. So it's got to be a big impact to the system.
Thank you. No, and absolutely. And it's one of these things where what was already being sort of planned for and panicked about a little bit from a number of the health researchers that I know, this idea of the aging population comes with it increasing complexities with healthcare and a lot of chronic health conditions that overlap as well. It's more intensive healthcare. It tends to be more expensive. And so if the pandemic hadn't happened, that would be the crisis in healthcare that we're talking about. Because that's what everyone was talking about in 2018 and the beginning of 2019. How do we plan for this sort of influx, these shifts in our population and the needs within our communities and within our province? So it was already near a crisis point in terms of our seniors care facilities. I had the benefit, I guess the fortune to lead a study, and we began in 2019, surveying healthcare aides and nurses within long-term care facilities in Alberta. We started the survey in October 2019, and we had to close the survey in March of 2020 because none of the healthcare workers had time to fill it out. We got 3 or 4 of them back in March 2020 that just said across them, like, people are dying, sorry, like, and put them in the envelope. But what we got from that earlier response, pre-pandemic, was already showing this crack in the system where healthcare aides in particular, who take on about 90% of the direct care in facilities, were completely overwhelmed. They were running without adequate time to even sort of say good morning to their residents or to provide personal care. Personal care, we all kind of say, like, well, it can't always be personal. Personal care means getting your nails trimmed or getting help getting dressed or getting a shower, getting taken to the washroom and things like that. So a real sacrifice of connection, a sacrifice of the quality of that care, and also of dignity was already being seen there. And that healthcare workforce within seniors care was already saying, we need help, we need more workers, and we need more spaces. So I had numbers here. The Alberta Continuing Care Association had put together a projection. It was QP Alberta. It put together a projection in like 2013, 2014 that said we would need several tens of thousands of additional beds by 2024 just to meet that population trajectory. And by 2024, we had accomplished, I think, 3,000 of 25 or 26,000 that were needed. So we're way behind, just in those senses. And what we're seeing today is instead this sort of like scramble to say, well, we can't have, we can't have a problem where seniors are taking up the majority of hospital beds. And it becomes, again, this sort of division, one group using more resources than another, and we're gonna have to find a solution for that. Send them to hotels, or send them in home care within the community, which is amazing if that's available, if the level of care is available, if people can afford it, or if that service is there for them. So again, we're still playing catch up to that wave and the shortfall that was there prior to the pandemic, and all of those workforces in every part of the healthcare system that seniors need, particularly their family care provider, are now like, we can't bolster the system. We can't take the pressure off of those long-term care facilities and keep people healthy and keep people at home. And that's going to become, I think, a real time bomb, unfortunately. Yeah, thank you. I'm just going to grab one more water because I still sound froggy. I'm sorry. Oh, I think the gentleman I was going to say the gentleman in the plaid. Yeah, and we're looking at these last two, so it will be back-to-back plaid, and I think that's, I support this initiative. Thank you.
No Scottish dancing with the plaid, of course.
I have a bagpiper at home.
Thank you for your insightful and candid comments. They're very poignant. Just a couple of points, if I may. Number one, so much of the discussion nowadays you hear is around the finances of funding. I think it's important that this group know that the significant majority of healthcare providers really, truly are not so much worried about the finances. They're worried about respect for them as workers and the work that they do wherever it is, in a care center, in a clinic, in a hospital. And that being downtrodden over the last decade or more is just a serious part of what we're talking about. The second point I'd like look at what we really could and should be doing, to help, see what our government is doing, because they're doing the exact opposite. They've taken a system which was not perfect, of course, and divided it up into a confusing mass of things. And if you do run any kind of business, you know that one of the things that you want is consistency and something you can count on. And within the healthcare community, if you take a somewhat broken system and you break it up some more, you have more confusion and no rug to stand on. So the third thing I'd like to point out is that the initiative that's going forward with increasing privatization, the room needs to know that there's abundant evidence on the US side of what happens when private equity funding comes into the healthcare system. We have abundant data to show that patient care is eroded, provider to patient initiative and bonding is eroded. And I know you know this, but the room needs to know that. The road that we're asked to travel right now is the road that's already well marked to say, danger, beware, do not go here. And so the gentleman in front of me in the non-plaid blue shirt here.
I don't discriminate against non-plaid here. I want that to be very clear. I appreciate your checks.
I'll be quiet very quick. But anyway, nonetheless, population needs to, if you want to band together. Talk to your MLA, pin him or her to the wall, and say, hey, look, we're fed up with what's going on here. And the interesting initiatives, of course, can be of different sorts. But just pin them to the wall, let them know the path that they're going down is the path of folly. Thanks very much.
I do really, really appreciate that. And like you say, kind of driving home the established evidence base on this. And not just from the United States, because as the lady in the back has pointed out, they are as unique a system as we are in the opposite direction. And like I said, I absolutely appreciated the comment from the front here, because like I said, when I started this, we tell this story about public health care like it's simple, like everything's free. And that's important in a lot of ways, right? Especially when we're talking to Americans. Like no, you walk in, everything's free, they give you everything you want. But it is more complicated than that. Everything's public. Well, it is more complicated than that. What do we mean when we talk about public? And if I had a couple more hours, I would love to break all of that down and have all of you contribute to that. So maybe we need a part deux. On the topic of breaking things apart, and just to get one more dig in at our southern neighbors, and I saw the pictures emerging from 1600 Pennsylvania Avenue this week. Anybody else seen that? Actual excavator just ripping the east wing off of this building, and I thought, oh, is that AHS? Let's put a gilded ballroom in. This is amazing. We don't necessarily have more doctors per person in Alberta, but we've got 4 more health ministers, and that's a start. What do we do here? It's really frustrating. I'm going to tell you guys a secret, because I'm working on something, and it's been one of the hardest reports I've had to do in a decade at Parkland Institute. I'm trying to pull apart this whole process of how the new model for healthcare services was developed. We went from, some of you will remember this, we went from a number of different health regions, and they were consolidated in 2008, and we made a single provincial model, and it was difficult, but there were some benefits to that. Maybe it wasn't working as well as it needed to. Okay. Why was everyone else copying us? We'll find that out too. But I wanted to ask, what model are they using here in Alberta? Where's the kind of, the cost benefit analysis, the business case? I interviewed a number of big names in AHS, formerly big names, one of whom is the vice provost of my employing university. You can do some digging on that. All of them said to me, Rebecca, it doesn't exist. We were on the committees. There was no discussion about this. there's no evidence, there was no model. It was not like, well, let's look at Switzerland and we'll take a dash of Denmark and we'll put a little bit of, what BC's doing, or there was none of that. It was, what can we do to dismantle AHS and make it as easy to keep under ministerial control as we can? And that should frighten us a little bit. Maybe, yeah. Choose your own level of terror, and we're open to that. So I want you all to know that some of us are trying really hard to dig into how these decisions are made and what the costs are going to be to Albertans, not just the financial costs, right? And there have been a lot of barriers put up. And a really big one has been the change in freedom of information legislation. It's just impossible. So many of the things we were able to push back on is because researchers and journalists were able to FOIP the real numbers. And that's going to be very difficult. So we've got to use our collective power to be angry, or metaphorically put MLAs to the wall. And then we, super quickly, for the sake of folks getting home.
First of all, I'd like to express my appreciation to the various healthcare providers in the various communities and what they have done for us over the past few years. Why? They're committed individuals, not very well supported sometimes, and they get a thank you sometimes from the province by saying, well, we don't need you. There's lots of examples of that, but I think we have a very good cadre of individuals in healthcare in Alberta and most of Canada. We do have problems, yes, and I think the example of a timely test is very important. It still is, although a lot of good examples of timely care happening in Alberta in spite of it. We also have a much easier thought about life as we age in Alberta, because we know we're not going to have to sell our house. We know we're not going to do all kinds of things that we can't afford that care. But on the other hand, we have prescriptions for seniors. The price is pushing up. We're supposed to make a larger contribution. There's things like that we're getting thank you back for supporting Alberta. And it is possible to understand what our healthcare needs are. There's plenty of statistical information reflected on every hospital or outpatient transactions in Canada. We can tell very easily what is coming up from medical requirements and based upon ages. The majority of healthcare you will find is by two groups. One is the seniors, the other is the little kids. That's where the money is, that's where the work is. And it's those type of activities that are done in our tertiary facilities by the public funded systems. There's no money in those services generally for private healthcare because the focus is on shareholder returns. Now, there's many good doctors that are in those systems, and I don't want to mischaracterize them. And I think we need to have more. But the coexistence of public and private, oftentimes seeing the private takes the good cases, the public gets all the difficult and long, costly cases. Yes. And oftentimes it might be the same position on both sides. But I'd like to make one suggestion. The current government has implemented some new tools. We have a referendum. So we need 3 or 4 referendums in healthcare. One should be about the fact that we're separating up everybody into silos and have something that says we should not do that. We want to have another that says, no, you cannot sell our public facilities. Yes, you may have not-for-profit organizations run some of them. We should probably look at some other initiatives, and you only have to have not so many people now to have these referendums, so it seems that that's what they wanted the public to do, not only to ask about leaving Alberta. I'm proud I signed up for keeping Canada. But anyways, I think there are things we should do. In Ralph Klein's time, and I do remember a fair bit of it, what turned him back somewhat was the groundswell and the lot of pressure that was put on by the public. Now, I think we have to engage the whole public this time, not just a certain sector group. But thank you for coming, and we'd like to see more good discussions and more times to tell the government something. Just one other how do you get the best services? Through teamwork. And that's building teams in healthcare, whether that's teams within the surgical suite, whether that's teams in the local office, but they deliver services in teams. Those two focuses will transform our systems, and we have to ask the government to stop hassling our good, reliable healthcare people. Let them deliver the services, please. Thank you.
Thank you so very much. I really appreciate that.
More men got the microphone than women. That's not equitable.
I feel like our mic runners have one more. Instead of me going on a long-winded response to this, which is mostly agreeing with you, but I'll happily, and can I offer you a personal chat at the end? No? Okay, I'm going to give this lady 1 minute. 1 minute, 60 seconds. Can she have 1 minute?
I said 2 more.
You said 2, I know. I said the plaid only.
I'm the bad guy here, not her. But I don't want to discriminate against women, so I'll have 1 more question.
One more. We get 1 more. And I'll keep my responses brief. You folks are so good to sit and wait. Thank you.
Yeah, I just wanted to say, if we remember what Dr. David Swan said, he was the medical officer of health for Calgary, who got fired by the government maybe 2 decades ago, and then elected to the legislature multiple times. He said there are only 3 things that your representatives will listen to. 1, if you say to them, I won't vote for you, I won't volunteer for you, and I won't donate $1. And he was in the legislature long enough to know, and that's what we have to do.
I can't even argue with that. Having just come off of a municipal election, I think those are fairly accurate. And just to that, so yes, a huge thank you to everybody in the audience who has been a healthcare worker, who knows and loves one. I pass it along. Your work is valued. And yeah, talk to your families and communities about their ideas as well. And maybe that is a referendum. We'll see how it goes with the public schools and Lukasics as well. It's a lot of work, but are we willing to put some miles in? So thank you, everybody.